minutes.
Good afternoon. It is very hard to be in between you and the lunch. I thank you all the organizers to give me the opportunity to talk in front of you regarding the management of knee arthritis. दो कार्डियोलॉजिस्ट की बात होने के बाद हार्ट चलना चाहिए, हार्ट चलेगा जब घुटने चलेंगे, क्योंकि जोड़ होंगे दुरुस्त तो हम होंगे तंदुरुस्त. मुझे ये लगता है कि अपनी जो फिलॉसफी है वो वी आर गोइंग बैक, वी आर अगेंस्ट द फिलॉसफी ऑफ द ट्रीटिंग. प्रिवेंशन इज बेटर देन क्योर, एंड दिस हैज लेड टू मेनी लाइफस्टाइल डिजीजेस. And we should be good physicians, superior doctors to treat the disease and the patient. Our motto should be that we should have replaced the illness, I in the illness with the we to be for wellness of the patient, and it has to be hand in hand. Patient should cooperate us, we should treat, and we should guide the patient accordingly. This has led, the lifestyle changes has led to newer inclusion of diseases, and for us, for me as an orthopedic surgeon, joint replacement surgeon, along with the dreaded lifestyle diseases, osteopenia, osteoporosis, osteoarthritis is rampantly present. The prevalence is increasing day by day. We, in our Indian society, earlier it was joint family. We were working, living together. Now, because of the nuclear family, the old people, they have incapacity. They lead to homebound, housebound, room-bound problems. And arthritis is one of the major problems where the mobility of the patient is reduced. Because of the less mobility, all other diseases, all other lifestyle diseases, all other lifestyle problems, they increase. In India, almost about 6% of the population is above 65 years. And in these old people, the incidence of arthritis is more than 60%. Arthritis is more in females because of low bone mass. Osteoporosis is rampantly present in them, and slowly and gradually, because of the diseases, the lifestyle changes, the eating habits, the bone density, the bone strength also decreases, which leads to increased arthritis. Arthritis itself is not a disease. It is a degenerative condition like cataract, graying of hairs, wrinkles. Arthritis has to be diagnosed, treated, and maintained so that the progression of the disease is not there. Slowly and gradually, the normal joints, the cartilage over the joints, the synovial fluid loses its elasticity, loses its properties. So there is bone and bone contact, which leads to pain, instability, and difficulty in walking, getting up from the chair, difficulty in daily activities. Cartilage and the synovial fluid in the joint, they help in maintaining the viscosity of the joint, the elasticity of the joint, and they act as shock absorbers. Whenever there is pressure on the joints, whenever you walk, whenever you jog, the pressure, the synovial fluid, the cartilages, they absorb the shock, and they did not lead to wear and tear of the joints. Ultimately, what happens? Arthritis is a dynamic process. The repair, the degeneration goes hand in hand. But with the age, progression of the age, the repairing is lesser and the degeneration is more. So it leads to formation of osteophytes, degeneration of the cartilage, losing viscosity and elasticity of the synovial fluid. It worsens slowly and gradually over the years, but unfortunately we are seeing patients which are younger in age. Knee joint basically has three bones, patella, femur, and tibia. And the joint comprises of 3 compartments: the medial compartment, lateral compartment, and the patellofemoral compartment. And the effect of arthritis is in all the joints, but basically it starts from the medial compartment. And there are several risk factors. Females are more prone. Bone mineral density decreases with the deficiency in vitamin D and B12. Repetitive trauma and stress injuries leads to many increased arthritis problem. Arthritis can be primary and secondary. Primary is a degenerative age-related arthritis. It may be present in mainly weight-bearing joints like hip and knee. And the secondary arthritis, which has known cause like inflammation, metabolic like gouty arthritis on all those, and post-trauma near the joints. The problems with arthritis are they have painful movements, the instability is there, difficulty in weight bearing, difficulty in getting up from the chair, walking on the stairs, and slowly and gradually the daily activities are being restricted. And the treatment which we can offer to the patient, the pharmacological treatment like NSAIDs, other analgesics, they lead to many kidney problems and all peptic ulcers and other gastritis and other problems. So what options we can give to them? We can control the pain by drugs, which I had mentioned, improve the joint functions by exercises, rest, physiotherapy, fomentation, short-wave diathermy. Weight is very important. If we maintain an acceptable weight to the body, the arthritis problem decreases. Intra-articular infiltration of steroids and hyaluronic acid is there, but they have very limited role to play. And above all, healthy lifestyle, eating good food, balanced food, and ultimately to make you mobile, surgery if it is required. What surgical options we can give? They are arthroscopic debridement and lavage. By arthroscopic debridement and lavage, what we do is we remove the frayed meniscus or the cartilage and osteophytes are removed. But it is not, you can bridge the time for going to the surgery, or if the patient is not willing for the surgery, we can offer it. Chondroplasty is there, but the overall time-tested result with chondroplasty is not there. The cartilage over the femur and the tibia are repaired during using arthroscope. Platelet-rich plasma and stem cell therapy is there in vogue, but it is not. It is a buying time therapy. Slowly and gradually, because of the progression of the degeneration, the joint they get more worse, and ultimately we have to go for surgery. One surgery which is very common, it is high tibial osteotomy. High tibial osteotomy is we remove the part of the tibia and realign the mechanical axis to redistribute the loading on the knee joint. It has an advantage of preserving the native joint, and technically when we go for TKR in these patients, it is more challenging. Another thing is unicondylar replacement, in which we remove only a part of the condyle, not both the condyles, only one condyle. Either it may be a femoral condyle, patellofemoral joint, it may be a medial compartment, or it may be a lateral compartment. In this, we only remove the diseased condyle, and this surgery has been preferred in younger patient. And the advantage is we can preserve the natural biomechanics of the joint. The difference between UKR and TKR is, in TKR, total knee replacement, we replace both the joints, the medial compartment, the lateral compartment, and patellofemoral compartment. And in the unicompartmental or partial knee replacement, we remove only the affected compartment. It may be a lateral condyle or it may be a medial condyle. This is the picture of total knee replacement, and this is the picture of unicondylar replacement. UKR, the selection for the unicondylar replacement is very stringent, because if we go for partial knee replacement in patient having 3 compartmental disease, the recovery would be very bad and the revision of this patient would be very fast. Replacement is needed when there is considerably patient load on the bones, walking distance is less, severe deformities, and patient is trying to avoid going to the social functions because of the deformity and incapacity. This is the way we do the replacement. We remove the affected cartilage and the bone from the femur, from the tibia. This is crowning of the femur with the implant, and the tibial implant goes into the medullary cavity, and these joints are being fixed with the cement. This is total knee replacement. This is the metal. We have different joints, artificial joints. Some joints have metal back support. Some joints have all poly support. This is the poly in between the femur implant and the tibial implant. This is the X-ray. You can appreciate that the joint space, which has decreased, which is not there, it has been maintained by the artificial joint. We keep our patients for 5 days, and the follow-up is after 10 days for stitch removal. Physiotherapy is important. It has an important role to play for increasing the endurance and the recovery time for the patient. Limitations after joint replacement is one should avoid sitting on the floor, squatting, and contact sports, because it would lead into extra loading on the joints. A successful TKR gives relief from the pain, correction of the deformity, improvement in the function, and improved quality of life. We want to add life to the ears. So, replacement offers that the patients are being comfortable in doing their daily activities. These are few of the results of the patients. Here I would like to emphasize, if the deformity is more, then one should go for bilateral TKR at a moment in a single stage. Otherwise, what would happen? I would like to show you in the videos. You would appreciate the problem. I would like to show few cases which we have done. See the X-ray. There is no joint space. This is the way she was walking earlier. This is the way she walks after joint replacement. See this patient. See how difficult he is walking. And we can appreciate that how he would be doing his daily activities. Only one knee has been replaced, the right one. The left one has to be done.
Sir, only 1 minute remains.
Yeah. This patient has hip problem. See the problem. We want to keep you mobile to enjoy all these things in the life. Thank you so much, the profession here.
Thank you, Fenil bhai, for giving such a nice right from prevention to TKR, treatment for knee joints. Thank you. And I'll request Dr. Shailesh Bhai Rawal to give memento to Fenil bhai. Thank you both of you.